Well, first off, I just want to kind of present what I've presented here before in terms of, what we sort of put together when we were starting our quality improvement program in terms of some guidelines. So a lot of times I get asked, what are your cutoffs? At what point in time, what is your hard cutoff for FiO2 or for PEEP or for RESC and what we really kind of found is a lot of times you can't, there are a few things you can have absolute cutoffs for, but a lot of times it's more about guidelines. So when we sort of started our program here, we came up with the concept of more medical stability guidelines, and we kind of set some criteria together based off of the literature that was available at the time in terms of these are scenarios when we would say, we're going to talk as a team. Like, if this is present before one individual person decides to mobilize a patient, we should talk as a team. So what we kind of looked at was evidence of poor oxygenation, so pulse oximetry less than 88% with supplemental oxygen, because we will titrate oxygen to allow patients to participate. Or evidence of having the FiO2 greater than 60 with a 10 of PEEP. So it's not to say that's our cutoff, that we wouldn't mobilize someone with higher scenario of 60% of 10 of PEEP, but it's just saying, we should talk as a team. This is obviously evidence of someone who's having some oxygenation issues. I had a great case of a woman who was morbidly obese, and when I went to see her, she was on 80% of oxygen and 20 of PEEP, laying very flat and not ventilating very well as a very morbidly obese woman. So if I had just looked at that in that context of, she's on these vent settings, that's my cutoff, I would have missed the boat, in terms of she's never going to ventilate well until we get her up. So, that's why I'm like an individual basis to just say, yep, these are high settings, come together as a team to discuss it. Evidence of tachypnea, respiratory rate greater than 45. Recent evidence of respiratory acidosis with pH less than 7.25. And then someone with a brand new PE or DVT. Again, it may not be that we're going to hold mobilization, but we should talk. There's very different types of PEs. It's very different to have a very small PE as opposed to someone with a submassive PE. So, in terms of, especially in the, a more compromised patient. So, again, not a complete contraindication, but we're going to have a discussion around this. Other evidence of hemodynamic instability, some of these may be black and white. Yes, we're not going to mobilize a patient who's having evidence of cardiac ischemia, for example. But, looking at vasopressors, one of the things we ask, we kind of use a 2-hour cutoff of, if they're on a vasopressor, what have the trends been for the last 2 hours? And this is what our therapist has to ask the bedside nurse. If we know a patient's on pressors, first, is it just a single dose pressor, or are they on more than one? Because that tells you right off the bat, that gives you a level of stability if they're on more than one pressor. But what's the trend been in the last 2 hours in terms of, have they been stable? Has it gone up? Have you been going down? Have they been, perfusing well and above their MAP goals? And then obviously, evidence of significant bleeding, cardiac ischemia. So, these are sort of the concerns. So we kind of started with this framework. So, and this is the part that we'll get into, that this is the newly published paper. Actually, it's not published, but it's in press. And what this came out of is there was a consensus meeting that Dale and I were both a part of, actually in Australia, June of last year, in 2013. And so it was a meeting of 23 international multidisciplinary experts, although the majority were from Australia. Dale and I represented the entire United States.
and Canada. I'm Canadian.
Canada, sorry.
It was also mainly PTs as well.
It was. It was out of the 23, 17 were PTs or physios, because we were in Australia. There were 5 intensivists and 1 nurse. So that was the group that came together for this consensus meeting. And what this was is kind of consensus to look around safety for mobilizing adult patients who are mechanically ventilated and critically ill. So we found consensus in all areas. So primarily we looked at, we had 4 categories that we looked at, and I'll put this up here and we'll go through them. But 4 categories we looked at were respiratory, cardiovascular, neurological, and then we kind of just had an other category that everything else fell into. We had consensus amongst all the experts there at this consensus meeting on everything in these categories except for vasoactive drugs. That was the only thing where we couldn't get complete consensus on, and that had to do more with the fact that they're in terms of dosages, combinations of vasoactive medication, different units that people might use to actually prescribe. So it was hard to come to a consensus that if it's this dose of this med, this is the cutoff or anything like that. So that was the one area where there wasn't complete consensus. Otherwise, there was consensus in all the other areas. Big things that came out of this, it was determined there was a systematic review done before. So whenever clinical, there is clinical evidence to document the safety and, efficacy of doing these things, that was used to make the consensus. Otherwise, it was also used by the clinical decision-making of the experts on the panel. So intubation with an endotracheal tube was determined to be not a contraindication for early mobility. So I think that's probably been brought home here. FaO2 greater than 60 with O2 sats above 90. Sorry, FaO2 less than 60 with O2 sats greater than 90 with a respiratory rate less than 30 is considered to be safe for early mobility if no other contraindications. The other thing I want to bring just before I start going through the actual categories and looking at these clinical charts, decision-making charts, is to say that in addition to just the 23 of us getting together and talking about this and coming to consensus, this also we brought to our international physical ICU rehabilitation, physical medicine rehab meeting that we held at ATS this year. And we had about 94 clinicians and experts in the area at that meeting of all disciplines this was presented to. Revisions were made, and at that meeting, 100% consensus was determined with the revisions made that then went into the statement. So I heard an earlier presenter talking about the red light, green light, traffic light system. I think this is great. This is the decision kind of categories that we decided to make in terms of guidelines for proceeding with early activity in mechanically ventilated patients. And I guess the one thing I do want to point out what all the guidelines were for active mobilization of patients. So we weren't writing guidelines for passive mobilization or passively getting someone up to a chair. So this is all kind of guidelines for when you're going to provide active mobilization where the patient is also going to participate at some level in their mobility. So I think I have it here. So this is actually our color coding. You guys have the text of this. So our green light categories are those where there's a low risk of adverse event. You guys may have seen this before yesterday a little bit in the questioning. So anything that's green light, there's a low risk of adverse event. Proceed as usual according to ICU protocols and procedures. Anything that is tagged as yellow, there's potential risk and consequences of an adverse event that are higher than the green level, but may be outweighed by the potential benefits of mobilization. Precautions or contraindications should be clarified prior to any mobilization episode. And if mobilized, patient consideration should be given to doing so gradually and cautiously. So this is, kind of your green is you go and it should be safe as you're following normal safety protocols of your unit. Yellow is like, we're going to have maybe discuss this a little bit or plan things out a little bit for, because, there might be a little bit more risk involved in mobilizing these patients, and it should be done a little bit more slowly and carefully. Your red light, again, isn't necessarily that it's never going to happen, but it's there. This is your scenarios where there could be significant risk or consequence of an adverse event, and active mobility in most cases probably shouldn't occur unless authorized by treating intensive care specialists. So this is those kind of, those case scenarios where you do mobilize someone. You do mobilize someone with femorally cannulated ECMO. That type of scenario. Again, that's a kind of a higher level decision. These are the activity mobility things that aren't going to occur unless authorized by a treating intensive care specialist in consultation with senior physical therapists and senior nursing staff. So it just may be that, the risks, the potential risk benefit may still outweigh the risk, but in generally, most cases you would not mobilize in those scenarios. So, and again, I'm just going to put this up here now. Again, apologize that we can't provide this for you, but when it is published, we will get it out to those of you that are able to provide your emails for the updates. So again, a lot of the things that we considered in green categories was, you know, we've broken into in-bed and out-of-bed exercises. So, you know, just the presence of an endotracheal tube or tracheostomy tube, these are green. These are proceed with your usual ICU procedures and plan of care. Again, the FaO2 less than 60%, again, green for in-bed and out-of-bed exercises. When you're starting to get above 60%, this sort of falls in line with what we've been doing already. It can be done, but you should have a conversation around it. You should recognize it and pause and plan for that and talk about it as a team. O2 sats above 90, again, green light for in bed and out of bed, less than 90. And this is, I should put in, I don't have all the footers on here. This is in the context of providing increased oxygen to support, and they still have less than 90% O2 saturation. So at that point, if you have a patient where, you know, out of bed activities, you know, you are going to be more limited if you're not able to bring their O2 sats up above 90. Same with respiratory rate, less than 30, greater than 30, again, more in the yellow. We're really not using high frequency oscillating ventilation anymore, so it's less relevant. But obviously out of bed activities are in the red there. Again, less than 10 PEEP is in the green, greater than 10 is in yellow. So evidence of ventilator dysynchrony, again, this is just one of those, it's an area where it's under discussion because, you know, obviously if they're not syncing well with the vent before we begin mobilization, you know, it should be more of a discuss as a team and figure out if there's a better strategy in terms of vent settings or medications provided. So, and any evidence of rescue therapies in terms of nitric oxide, prostacyclin, again in the yellow. Prone positioning we mean specifically like we've put them prone from a ventilatory maneuver standpoint as opposed to any type of chest PT scenario, but again, those are going to be in the red categories.